We are going to get started. Hello, everyone, and welcome to our Advocacy Ground Rounds event. My name is Adili Elmi. I am a current PGY3 internal medicine resident at Case Western Reserve University and University Hospitals in Cleveland, and also a current Capella Fellow. So before we get started, I want to take a quick minute to invite you officially to join Doctors for America and DFA's fight to improving healthcare for all. Becoming a DFA member is easy. Just go to our link in the chat, select your membership level, and pay your annual membership dues to support DFA's work to improving healthcare with incredible programs like the Advocacy Ground Round series. Tonight, we will be live streaming the presentation to Facebook, as well as recording all materials will be available afterwards. So we'll start with a few quick ground rules for this educational session. 1, we welcome your questions, okay? And there's no such thing as a stupid question, so please ask. Remember to use the Q&A feature in your Zoom, and we'll address your questions during the second half of our session. And also look out for comments in the chat. DFA staff will be sharing helpful links in the session as well. All right. Now, on to our amazing speakers tonight. We are thrilled to welcome Dr. Peter Lurie and the amazing Vera Rosenthal. We'll start with Dr. Peter Lurie. He is the president and executive director of the Center for Science in the Public Interest. Previously, Dr. Lurie was the Associate Commissioner for Public Health Strategy and Analysis at the Food and Drug Administration, where he worked on antimicrobial resistance, transparency, caffeinated beverages, arsenic in rice, fish consumption by pregnant and nursing women, expanded the access to investigational drugs and prescription drug abuse. He also previously served as the Deputy Director for Public Citizens Health Research Group, where he addressed drug and device issues, co-authored the organization's Worst Pills, Best Pills Consumer Guide to Medications, and led the efforts to reducing work exposure to hexavalent chromium and beryllium. Earlier, as a faculty member at the University of California in San Francisco and the University of Michigan, he studied needle exchange programs, ethical aspects of mother-to-infant HIV transmission studies, and other HIV policy issues domestically and abroad. And now, to Vera Rosenthal. Where we start? She's a strategic communications expert with over 15 years of experience, translating complex health policy and regulatory science into transparent, actionable message. Most recently, she served in the FDA Center for Drug Evaluation and Research, where she led communications on high-profile neuroscience therapies, efforts to combat counterfeit and fraudulent medical products, and emerging public health threats, including COVID-19. Having experienced the FDA's recent reduction in force firsthand, Vera offers a unique insight into how the internal shifts are affecting external messaging, the agency's ability to maintain public trust, and the efforts to counter health misinformation. I will now turn it over to Dr. Lurie to get us started.
Great, Adelia, and thank you very much for inviting me. I'm thrilled to be here. Let me just say just a little bit about my current job, just so that people understand what we do. The Center for Science in the Public Interest, CSPI, is an over 50-year-old public interest group, so formed in the early 70s. We mostly work on food, but we've also expanded recently into vaccines, drugs, medical devices, and so forth. We pride ourselves on being fiercely independent, and one expression of that is that we don't accept money from corporations that are involved in health, or really any corporations, and only very trivial amounts of money from the federal government, and then only for research. So that's who we are, and we have activities in Washington that involve lobbying, that involve activities in the regulatory agencies, particularly FDA and USDA. We sue the government periodically. I can talk about that more if you like, including the recent NIH contract termination case. We're active in the States. We have a magazine called Nutrition Action that has about 200,000 subscribers at present. So we do a bunch of things. That's who we are. That's who I am. And that's a kind of background for what I wanted to talk about. So I had worked, as Dilly pointed out, at a different public interest group called Public Citizen before this. But when the Obama administration came in, I thought it might be interesting and rewarding to take a job working at, an agency we'd kind of looked at. I don't want to call it the enemy, but the other side to be sure. And took this job, and it was a notable thing for somebody like me to want to work at a place like that. And one of the first things I learned within a week, I would say, well, probably two things. The first was that the agency was so much bigger than I ever thought it was. We had focused in on drug approvals in particular, especially for products that had run into safety problems. And we've been involved in many of the debates over the years, like Vioxx and, on and on. All the drugs that there was a fight over, we were involved in. Ritalin, so on. But I learned that the agency was much more than that. I always knew that they were not just in drugs, but also in devices and foods, tobacco, and so on. But it was more than that. All of the public health aspects of the work that they did that were not adequately appreciated. The second thing that I realized, and this I think is relevant to part of what I want to talk about tonight, is that although I, didn't have an especially favorable view of federal employees from the outside, after about a week, I found myself walking down the corridors over at White Oak, which is where FDA's headquarters are. And I thought to myself, it's funny because people in all these offices, they seem like really sincere and they seem like they're working really hard. They seem like they're trying to protect the public health. And of course they were. And I learned to appreciate all of my colleagues, in the time that I was there. It was a kind of revelation. It's maybe an embarrassing revelation, but and a revelation all the same. So as I say, I learned that FDA was much more than drugs, but I also know that this audience is especially interested in drugs. So let's just talk about that for a bit, and then a few other selected topics, particularly in the context of the changes going on in Washington right now. So there's long been a rap on FDA that it's too slow to approve drugs, that drugs come on the market in Europe in particular before they do in the United States. People have to go to Mexico to get things. There was a time when FDA drug approval times were pretty long, in fact. It could be as much as a couple of years. But especially after the agency started accepting money from the industry in the form of what are called user fees, those drug approval times plummeted. And in fact, the agency is required in most instances to finish the review of a drug in either 6 or 10 months. In fact, FDA, if you take the entire set of drugs that come on the market in a given several year period, and you ask anywhere in the world, and you ask yourself, in which country did those drugs first come on the market? The extraordinary answer is that in over 2/3 of cases, the drug came on the market first in the United States. So anybody who tells you that drugs are coming on the market in Europe first is not well informed. It's an extraordinary thing that 1 out of 200 countries could be responsible for 70% of first approvals. That's a really remarkable fact, and we shouldn't lose track of it. All the same, FDA has changed its approval standards, not its standards, but the way it approves drugs over the years. There's a number of expedited pathways that allow, especially drugs for serious conditions or serious or life-threatening conditions, to go through these expedited pathways, the most famous of which is accelerated approval, in which you can get approval based on a kind of proxy measure, a surrogate marker of effectiveness, but then you're expected to later produce a study that proves the actual effectiveness of the drug. In point of fact, that's been a glide path to approval for a number of drugs, many of which have been unable to actually demonstrate a benefit on hard outcomes in subsequent years. And if that does happen, FDA has had a lot of difficulty in removing such drugs from the market. There's also a belief, and I think we may see more of this in the coming months, that if a drug makes it, for example, to phase 2 of the drug approval process, it is very likely to succeed in the final stage of drug approval, which is called phase 3. This is also false. Many drugs that make it to phase 2 will fail in phase 3. when they're actually subjected to long-term, properly conducted randomized controlled trials, often with a placebo. And we actually, when I was at FDA, because there was a criticism of FDA on just this point, we wrote a report, subsequently removed from the website by the previous Trump administration, that showed how, not how often, but that there were many instances in which this actually took place. Okay, so that's a little bit about drug approval. We can return to that in the Q&A. I want to touch on just a few other things that are kind of the moment. One of them is the cutbacks that we have seen in the staff at FDA. And these, of course, they're not restricted to FDA. They're across the government in many respects. But at FDA, 21% of the staff have left. At HHS, it's 18%. So that's that's several thousand people, many of whom are respected scientists or people with skills like Vera, who have been forced out either through being riffed, as it's called, or else by providing these packages that make it almost too attractive to not leave, especially when the whole climate is as dark as it sometimes is. So there have been a number of these firings, a number of important functions, really all the important functions at FDA, I think, have been threatened to one degree or another. That means not just drug approvals. It means all those other things that I learned FDA did, all of the compliance work that they did, all of the inspections, all of the work, the pharmacokinetic work to establish that a drug actually dissolves or that it gets into the body properly, that it has a proper expiration date, that it's properly packaged, properly labeled, properly advertised. All of those things are under threat. And in particular, though, the thing that the Trump administration has gone after are people who work in communications and in freedom of information. So people who are expected to resolve the Freedom of Information Act requests that are submitted by external parties, such as myself. So it's interesting that those have been particular targets. I think, authoritarian regimes have a tendency to want to move communications high up in an organization, to centralize things and to control message. And I think that that's what we've seen within FDA. And then within HHS, we've seen it within HHS. And that's what we're seeing today with the firing of the CDC director after she wasn't willing to toe the line. That's not the way it used to be, but under the current regime, that is absolutely what we're seeing. There's a very interesting exception, though, to the cutbacks in the freedom of information staff, and that is they managed to keep on a couple of people whose job it was to respond to two Freedom of Information Act requests that had been submitted by people who worked with RFK. Those people were kept on, but many of the rest of the people in the staff were let go. So there's been that kind of selectivity. So that's one kind of topic about communication, advisory. And now I want to move on to advisory committees. We hear a lot about those. Those have been in the news a lot. To be clear, what they are groups of outside experts, often from academia, who advise the agency. Outside people, they have to be vetted for their expertise. They also have to be vetted for their conflict of interest. And so then you have these advisory committees. FDA has, maybe 4 dozen of these across all the different parts. And then many other health agencies, including CDC, have their own. What we've seen at FDA are a series of meetings that address the kinds of topics that would come up before an advisory committee in the past, but instead take place in these kind of fireside chats in which carefully selected individuals are invited and give often idiosyncratic views that are not well supported by data. And so we've seen that with respect to estrogens. We've seen that with respect to, of all things, talc. We've seen it with respect to SSRIs. I expect there will be more of these, and they basically evade the usual process, which is to go through the advisory committee process. We've seen it outside of FDA as well. You see it at the U.S. Preventive Services Task Force, where they canceled a meeting. That's going to be critical to see if that group ever meets again. And just today, I learned that FDA's Arthritis Advisory Committee has just been disbanded. That sounds like nothing. I mean, the Arthritis Committee is just, an ordinary committee. It's not vaccines. It's not controversial. But actually, it's the non-controversial aspect of it that's worrying. I mean, if they're going to the trouble of disbanding this committee, then what does that say about all the other non-controversial committees that are out there? Now, with respect to the vaccine ones, of course, it's been a massacre, particularly over at CDC, where they've meetings have been postponed, and then when they take place, everybody gets fired literally, and then a group of hand-selected people, all but one of whom are known to have very strong anti-vaccine views, are invited on instead, and then they have a meeting, and it has predictable consequences for what gets recommended and how things are indicated for use of vaccines. So we've seen a lot of that. One of the interesting things is that RFK has tried to kind of demonize these committees and, in fact, the agencies themselves, including FDA, by saying that they're enthralled to the industry. And, it's a complicated question that we can talk about more about these user fees, to be sure. But one thing is true is that conflicts of interest are carefully screened on all of these committees. And in fact, they are low. And I say this because I published a paper in JAMA just last week in which we looked at the rates of conflict of interest on the FDA and the CDC advisory committees for vaccines. And they're down in the low single digits. Now, 20 years ago, they were high, or at least much higher. But nowadays, it's single-digit stuff, and the vast majority of people do not have conflicts of interest. Despite that, RFK repeatedly says that it's just riven with conflict of interest. He points, though, to a single study done by a congressional oversight committee, which looked at advisory committees on just one vaccine back in 2009. That is not really a way of looking systematically at what's going on these advisory committees. So that when you hear that, don't buy it, because it's just not true. And you can read our paper in the JAMA if you're looking for graphs that prove it. So let me close off by talking about what really matters the most when it comes to FDA and what matters to HHS. And that is the integrity of science. That there's nothing more important than that. And what we have seen is an erosion in the way that science is conducted in this country. We have seen attacks on research in general, on the enterprise through these attacks on indirect costs. We've seen them on particular kinds of research related to DEI, vaccine hesitancy, race of any kind, really, and South Africa, of all things. All of these have come under scrutiny, and billions of dollars of grants have been terminated as a consequence. And then, of course, they canceled all this money for mRNA vaccines as well. So, I mean, it's a dire time, and things that are, favored will be funded, including the pet vaccine technology favored by a couple of people who are now high up in NIH. There's $500 million set aside for their pet technology, even though most vaccinologists think that it's an old-fangled and not very promising technology at all. But that's the way it goes these days. So what we have, though, is people who come in and talk, though, about a good game about the rigor of the science that they will apply. And so, we actually might see a kind of rigor, perhaps even an undue amount of rigor when it comes to vaccines. There, one can imagine, and we've even seen standards applied that go beyond what FDA has ever applied. And so people who are super duper data people might even see the worth of that. But what's striking is that the rigor seems to be reserved only for vaccines. You certainly should not be expecting it when it comes to all the other things that RFK actually favors, like regenerative medicine, dietary supplements, all the other kinds of alternative medicine like IV hydration clinics, compounding, all those kinds of things. There's no reason to expect that there will be that kind of rigor applied consistently to them. So at the end of the day, this so-called MAHA movement, Make America Health Again movement, has just put out, or actually had leaked, its report with recommendations. And the interesting part about it is that it actually pulled back a number of things that it had said it would do in an earlier report. And the difference between the earlier report and the current report is probably two things. And these were the two reasons why the MAHA movement would always be limited. The first is that the GOP is an anti-regulatory party. That's who they are. It's in their nature. And so it was inevitable that big industry would come in and complain about some of these things. Just the way it's inevitable that, the meat packers are going to complain when all their workers wind up getting deported, or the people who are growing fruit find that they can't get their cherries picked anymore. There will be pushback from industry. And the drug industry is certainly going to be one of them. Another one has been the chemical industry, which did not like seeing its pesticides disparaged in earlier versions of this report. And sure enough, when the second report comes out, those things are gone. So you see those two forces are the ones that will ultimately constrain the worst instincts of this MAHA movement, the sort of anti-regulatory buzzsaw, which is standard operating procedure in GOP administrations, and then the influence of industry. So I actually hold out some hope. The full report we're hearing is going to come out next week. We'll see if it gets pulled back even further. But it's interesting times that we're in. All I can say is, hold tight, stick to your principles, look to science, ask yourself twice when you hear something, particularly on vaccines coming out of CDC. Look for other respected authorities because the quality of information currently being supplied is just not what it used to be. Okay, I'll stop there.
Well, thank you so much, Dr. Lurie. Really appreciate all that information. And now I'll turn it over to Vera.
All right. Well, thank you so much, everyone, for joining us tonight. I'm really excited to be here and to provide what is hopefully useful insight into the current FDA landscape, although it's a little difficult to follow after Dr. Lurie. So to give some background, I'm a former health communications specialist. I was with the Center for Drug Evaluation Research, otherwise known as CDER, in the Office of Communications in the Division of Health Communication. My entire office was part of the reduction force that took place on April 1st, 2025, although we weren't officially let go until July, which, among other things, was extra confusing. So just some background on the FDA. The mission of the FDA is that it's responsible for protecting the public health by ensuring the safety, efficacy, and security of human and veterinary medicines, biological products, and medical devices, and by ensuring the safety of our nation's food supply, cosmetics, and products that emit radiation. One thing I really want to point out and make you aware of is that FDA-regulated products account for 21 cents on every dollar spent by the U.S. consumers. And exactly as Dr. Lurie mentioned, we don't know the official numbers of departures because HHS has been wishy-washy about it, but ProPublica announced this week that they believe 21% of staff left the FDA through reduction in force, early retirement, and other means. And then to give a little bit more detail about CDER, CDER's mission is to protect and promote public health by helping ensure that human drugs are safe and effective for their intended use, that they meet established quality standards, and that they are available to patients. So I want to talk more specifically about the CDER communications process, specifically what we worked on in our office. Our mission was to provide strategic direction for CDER's internal and external communication strategies. At the end of the day, our goal was to work with our program offices to ensure that the content we put out was the right message to the right audience in the right medium at the right time. So I wanted to give two very brief examples of communications products and how they've changed since the administration changed and since the RIF. One is a press release, which, you've all heard of. That's what I would call an agency level document. And what that means is that while CDER staff was involved in crafting these documents, they ultimately were finalized through the Office of Commissioner, which, for example, is where Dr. Lurie worked. CDER level documents would include CDER alerts and statements. And these were at the CDER level because they are often more specific to CDER audiences and generally included a call to action. So topics can include things like making the public aware of counterfeit products or warning providers about medication mix-ups. So I wanted to give an example of two press announcements, one that happened before the communication staff was cut and one from after. So in January of this year, FDA approved a novel non-opioid treatment for pain medication. And the press release, one, explained how the drug worked and what was so important about it, but also provided context by sharing it or comparing it with what we wanted to come out of the FDA overdose prevention framework, which is a framework that encourages development of non-opioid drugs for acute pain. A more recent example, when I was looking at the website this week, this was from August 22nd, was FDA announced that they would be hosting real-time adverse event data. What this means is there's a database called FAIRS, and it's where content is posted when the agency receives MedWatch alerts and other alerts letting them know about issues with drugs. The FAIRS data is raw data. There is little context, and having the data published there without any context is not useful for the public. So while the administration wrote in their press release that it is improving their radical transparency, it really isn't going to make any difference. And so to give you an example of the CEDAR alert from January of this year, we discovered there is an issue with epinephrine nasal solutions being confused with IV epinephrine products, which could obviously be dangerous for the patient. The alert was sent to specific provider organizations, but we also posted on the website so that these groups had a place to point their members to, and for transparency. Since March, there have been no alerts posted, which is not surprising because all of the CEDAR communications staff was cut. So this does not mean that there is not information getting to specific groups, but we have no way of knowing it. And again, these are just two of the many ways FDA communicates with the public. My brief thoughts on how we can navigate this changing landscape. The first one is focus on sorting through the noise and recognizing all the mis and disinformation. I would love to be able to still tell you to look to government websites, to be excited about what we put on the website, but unfortunately, now my advice has changed to trusting information coming from other sources, such as medical societies and advocacy organizations, and listen to trusted experts, read peer-reviewed articles, and continue participating in events like this one so we can learn from each other. And last, but definitely not least, connect with each other so we can commiserate and also sit tight, as Dr. Lurie said, until we can make it through this. And on that note, I'd also love to connect with you, so please find me on LinkedIn if you would like to continue chatting. And that's all I have, so thank you so much.
Wonderful. Thank you so much to our esteemed speakers tonight. And now we will move on to the Q&A section, and I will start us off. And this can be answered by either of you guys. So what do you think healthcare providers often misunderstand about the FDA's role in clinical care and public health?
Well, I think I actually sort of answered it at the beginning, which is people don't really understand the expanse of what it is that the agency does. When I was there, I found myself, as Vera said, I was in something called the Office of the Commissioner, which is sort of across the top of all of the different centers, including the drug one where Vera lived. So we do see something different there. You tend to see much more policy and so forth. But that's actually something with understanding itself. The drug approval decisions, which is what most people think are the bread and butter of what FDA does, are in fact not decisions that are made, at least until now, high up in the agency. They are made, by very talented, highly skilled mid-level folks. And I don't want to be disparaging at all, but they're not, the head of the drug center. They're certainly not the head of the FDA. They're not the deputy head either, or you get down a couple of levels before you start to encounter the people who are actually reading the material that the drug company submitted in support of their application. And indeed, most of the approvals that FDA has to consider are not actually that difficult as a decision. Some of them are just obviously lackluster and are not likely to get approved. And probably a majority of them are really quite good, and are likely to get approved. And so they don't usually rise to the level of any significant controversy. It's only the occasional ones that you hear much about, the only occasional ones that make it into the press, and only the occasional ones that involve the involvement of the center director, much less the commissioner of the FDA. So when I was, working with the commissioners, all we'd really hear was, oh, by the way, drug X and such is going to be approved next week. And it was just purely informational. Unless something really crazy was going on, which it wasn't, they'd be like, okay, well, that's good to know. And then you just move on because there were 10 other things that weren't drug approvals that you had to deal with. So what we're seeing now, though, is something very different, because here we have examples of indications for vaccines, for example, where not only is the center director, who is also, by the way, in the office of the commissioner somehow, or at least used to be, somehow that's the case. Not only is he making the decision about what the indication for the COVID vaccines will do, he's actually overriding all of the review staff who feel differently from him. This is not business as usual. And I just don't want folks to think that. I mean, there will come a time where we revert to business as usual, and it will be a better time, because the drug review is actually, in FDA terms, sort of a rudimentary action. I don't mean to be pejorative in that. What I mean to say is it's just the nuts and bolts of what they do. 40 of them a year for new chemical entities. That's what they do. Most of them aren't controversial, but that's certainly not the environment in which we're operating today.
And another question that we had was, could the reduced staffing at the FDA lead to lapses in regulatory enforcements? And if any, where might we see the first effects? And Darren, maybe you can speak on this a little bit since your recent work.
Sure. So I can't really go into a ton of specifics, obviously. But for example, when they cut the initial cuts to staff, they said we're focused only on communications, people doing the budgeting, travel, etc. But really, they cut, like I said, 21%. Those weren't all communications staff. A lot of them were inspectors. So, you can assume that our plants might be less, like drug facilities and plants might become less safe. Some of the research scientists, like Dr. Lurie said, some of the actual people reviewing the applications. And I've seen those applications. They are intense. There's a lot of research. We request a lot of data, and people do a lot of digging to make sure that everything is how it should be before there's approvals. So again, I don't have the breakdowns of numbers. Even, for example, in our office, they cut the entire web staff, and then they realized they had to fulfill statutory requirements to post drug labels, and so they brought people back. So I don't know if that really answered the question, but.
Well, I'll answer it in a bit of a different way. Part of the thing that's frightening is that there will be a general decline in the quality of what the agency produces, despite the hard work of the 80% of people who remain. Partly because, and of course, their morale isn't what it otherwise would be, and people with low morale don't produce the way people with good morale do. But what's frightening about it is that much of what could go wrong may not be detected, right? So what will be detected are things that happen acutely and that are kind of spectacular. So if there is a drug that is somehow contaminated, and it turns out that the place wasn't inspected for longer than the usual periods of between inspections, and then people get killed, we'll notice that. And if there's a foodborne outbreak, right, again, due to failure to inspect or due to some loophole created by a deregulatory change to some guidance or regulation, we'll detect that too. So it tends to be these acute things that cause obvious illness that can be detected. But all of the rest of it, things that might be seeping into the food supply at low levels, but not enough to cause an outbreak, or contaminants that somehow elude detection, all of these things can be happening. We just won't know because there isn't the surveillance system adequate to detect them. So I would look for those things. That's where it will first crop up. Those kinds of areas: contamination, infection, outbreak. But know that behind all of that are other whole deep set of problems that are probably going undetected.
Just one follow on to that. One of the things we public healthers love to say is that when public health is working, you don't hear from us. So as Dr. Laurie said, all those behind the scenes things that are going wrong and will continue to go wrong that we will then hear about when they bubble to the surface, that's a public health failure.
Very, very true. And Dr. Lurie, I think you've already kind of alluded to this next question, but are there like specific types of drugs or devices likely to face like more delays or less quality reviews, like due to these changes?
Well, I mean, I think the big difference, will be, is it something that RFK cares about? I mean, there's no question that they do a good job of having their priorities permeate the entire agency. You got to give them credit for that. If the guy is interested in vaccines, all 80,000 people who work for HHS are aware of this. And if a vaccine comes up across their desk in some way, shape, or form, they know they've got to pay attention to this. So it changes the nature of the review and gives, vaccines this kind of prominence, somewhat ironically, that, otherwise wouldn't have. So I think we can expect to see a lot of attention on vaccines. I think you see, ironically, so-called higher standards applied to vaccines than you would to other products. I think you will see lower standards applied to those things favored by the MAHA movement, a lot of things in so-called natural medicine and holistic medicine, what have you, supplements in particular. You expect that. And then, oddly enough, we're starting to hear something about the administration's priority vouchers, which is, Vera, I don't know if you know much about this, but it's sort of hard to understand concept in which within the drugs that are already being reviewed, certain of them the agency would commit to reviewing especially quickly. Like instead of in a month, 6 months, which is what is done when they have to be reviewed quickly, like in a month. When there's a lot of magical belief in AI, and AI is going to make this happen somehow. I don't know how, but they say it will. And some of the criteria for these priority reviews are things that go very much beyond FDA statute. They have to do with drug shortages. They have to do with drug pricing. They have to do with domestic production of drugs and even foreign policy concerns. And that is really, for people at FDA, I mean, I'm not there to talk to folks about it, but I imagine that's deeply painful to people because what people at FDA feel on the drug review side is that they are policing a very simple standard, the standard of safety and effectiveness and the relative ratio between the two. That's what they do. They don't care about price. They don't care about access. None of that stuff is their problem. Somebody else has to worry about that, okay? But that's not FDA's job. FDA's job is to figure out if it works and is not unduly unsafe, right? That's the job. So to have these other factors potentially injected into the drug approval process is absolutely anathema to an FDA reviewer, because then you feel that you're a pawn in some other kind of game, right? The administration's interest in tariffs or the administration's interest in bringing, drug production home. But the average reviewer is not interested in that. All they want to do is identify the safe and effective drugs and make sure that people get them.
Really appreciate that thorough response. Now we'll take questions from our audience, and we'll start with Suraj Joshi. I apologize if I butchered your name in advance. So the question is, it seems like the medical profession's response to changes at HHS/CDC so far has been to privatize the work done by CDC, ACIP, etc. In addition to privatizing funds flow for research, do you believe this is a sufficient response to preserve the integrity of these recommendations and research, and what else can be done?
I'm not certain I understand the question, but I think what Suraj is saying is that what people are doing, because of the kinds of deficiencies in the veracity of government information that Vera talked about, is that they're trying to set up alternative structures that can be trusted. I think that's what he's referring to, and I think that's completely understandable. I mean, I think we've seen that in vaccines. There's I think it's called VIP. I think it's called, which is a kind of, it's almost like an alt CDC, in which there will be a group of people who will make recommendations. Well, they say based on the data, not based on whatever it is that the new ACIP, the CDC's committee, will be saying. So it's kind of an alternative source of information. I think that that's a reasonable thing to do. I mean, it's really a tall order, though. I mean, I've seen over the years occasional times where people have had ideas like, for example, that a state, or maybe in some instances the Department of Defense, should be able to review and approve their own drugs. And that has always been a terrible idea, because it completely misunderstands the amount of work and the number of people who work on any given drug review. It is literally hundreds of people who in some way, shape, or form have their hands on that review. And it is literally impossible to recreate that somewhere else. I mean, I'm all in favor of people, trying to do that best they can, but it will never be an adequate substitute for the way that FDA does it right now.
And to add on to that, I'm not quite sure if I'm answering the question being asked, but in terms, like I was saying earlier, in terms of where people should be getting their information now, I would recommend going to, professional societies and medical associations and advocacy organizations, because they care, and honestly, the administration doesn't, as we've talked about. So is that a sufficient response? I wouldn't go that far, but not because people aren't trying, but because there's really only so much that can be done.
I mean, I guess I'll just add a wrinkle to that, which is there's probably some government information that I would still trust and some that I wouldn't. If it's on vaccines, I just probably wouldn't. If it's on autism, I just probably wouldn't. But, if you get into some obscure corner of medicine that is, not attracted the secretary's attention so far, it's quite possible that stuff is unperturbed and may still be reliable. So that's actually, that, of course, that's part of the difficulty, right? It's a lot easier to be able to say, believe the government or don't believe the government. My message is believe it sometimes and believe it more in some places than others. But actually implementing that is really difficult. And that's part of the problem, is that it creates imprecision, uncertainty, and lack of clarity as much as anything. And it permeates the entire information ecosphere, not just vaccines.
Thank you, guys. And Barrett, this is more, I think, in your alley. Could you speak on the process that results in the public communication, and how does the FDA decide what should be communicated to the public?
Absolutely. That's my bread and butter. So as I was saying, we were the strategic, again, I'm speaking specifically for CEDAR, although I'm aware of what the other centers worked on. But so we were in the strategic communications branch. So we were split into beats for the way like a newspaper might be. So I focused primarily on our Office of Neuroscience and our Office of Compliance, which is broken into two big buckets. So like Dr. Lurie was mentioning about compounding, and also health fraud, which things like counterfeit medicines fall into, as I mentioned earlier. So what we would do is we would look at all the data, whether it's approvals coming up or coming situations, even advisory committees sometimes got press. When working in tandem with the program offices, we looked at who needs to know this information, how do they need to know this information, and what do we want to say to make sure it's clearly communicated. So again, press releases and seer statements are two of many different ways. We had a group that did user list or advocacy listening sessions. Our DDI, which is the Division of Drug Information, answered calls from consumers basically all day, every day. And so they would come to us and say, hey, we got this question. We think this is what they're asking. Can you help us determine the best way to provide that information? So at the end of the day, it all comes down to strategy. And I'm happy to talk more later about all the other ways we provide information if you're interested, Janet. But
I think this is a good segue into answering the next question because it's on the minds of a lot of people. And that is like, what steps can we take to reduce the fears and the chilling effect, particularly like at universities, but also at like some non-for-profit, organizations, as we're well aware, these tend to paralyze some from like speaking out and, advocating on Trump's administration actions that are clearly, fly in the face of like, especially science, and evidence.
Let me ask, I'll answer that from the public interest point of view, and I'll mostly answer it by telling you what we're doing. Even actually before the Trump people got reelected, we created a misinformation campaign through which we tried to identify particularly salient examples of misinformation and then, to debunk them. So at the moment, for example, we're quite focused on seed oils that many of you might have heard about. These are actually rather healthy oils that somehow have been tarred with the idea of being unhealthy and with the idea that they should be replaced by, of all things, beef tallow, which actually is unhealthy. But that's where we are. And so, we've done a bunch of work putting out materials in all the different media that try to take that on. That's one thing we've done. This isn't a misinformation thing, but one thing we did, I hinted at this earlier, is we sued the NIH over those grant terminations. And that's actually goes a little bit to the premise of your question, which is, there were literally hundreds of people who had been terminated, but very few people who were willing to put their name on a complaint because if you were a Harvard person, you were like right in the middle of everything that was going on around Harvard at the time. The administration didn't want you going out and putting your name on a lawsuit. Well, the irony of it was that I was on a grant with some folks up at Harvard to an absolutely trivial degree, like $150. I mean, really like nothing. And it turned out that in the abstract for our application, well, it was actually funded, right? For the grant, there was some mention of trans women in the abstract, and that was enough to be picked up in the algorithm, and we got terminated. The Harvard people wouldn't put their name on this lawsuit, and I don't blame them. But for my $150, I was willing to do it. And so I became a plaintiff in this case, which ultimately is a case that you might have heard about. We initially won and got some $700-800 million of grants restored. But unfortunately, just in the last week or two, it went all the way up to the Supreme Court. And in a complicated decision, they ruled against us. So it's not finished by a long shot, but it gives you a sense of, well, groups like ours, it's actually, I'm in a really good position because I can speak freely. I'm not, my salary is taken care of. If anything, I'm encouraged to speak out. But you have so many other people who just aren't able to. And we were lucky that they happened to put me on this grant, and I was willing to speak out. Otherwise, they wouldn't have been represented in the lawsuit.
And that's where we're so fortunate to have people like yourself who can speak without the fear of retribution. So thank you so much for that. And the next question is from Sandhya. And the question is, how does the FDA reconcile its dual mandate of safety and access when REMS protocols intersect with antitrust concerns? And is there a review process for REMS design that includes economic impact on delayed competition?
Peter, I'm going to have to let you answer that one.
All right. Well, I don't know that I can because again, not sure that I fully understand it, but I'll resort.
I'm going to repeat it.
No, it's okay. I'll resort to what I said earlier, which is that by and large, FDA is not interested in those things. The statute that FDA enforces is about safety and efficacy and the ratio of one to the other. That is what they do, and they ensure that the products that meet those standards are properly produced, labeled, distributed, so on. But they're not interested in price, and they're not inherently interested in antitrust or any of that. Now, it is true that FDA does police what are called exclusivities. Okay, so there are two kinds of concepts here, which might be what the question is getting at. There are patents, which are not enforced by FDA. Those are, as you might expect, enforced by the patent office. And then there are things called exclusivities, which in the drug world are probably usually more important than patents. And those exclusivities are things that FDA does actually have the ability to grant, depending on the way that the drug might have come to market. So there are exclusivities around being an orphan drug, right? A drug for a relatively rare disease. There are exclusivities if you conduct certain pediatric studies and attempt to change the label so that the product could be administered with proper dosing information to children. So there are those kinds of things. There's another exclusivity that is intended to encourage the development of antimicrobial drugs. But those kinds of exclusivities are created by the Congress, and so the policy decision is made at the congressional level. FDA then tries to be, the fair umpire that just sort of calls balls and strikes, and so says, well, this drug is too common, to be an orphan drug, so you don't get that. Or, the study that you did for this pediatric indication doesn't really meet the criteria established by the Congress or by us in guidance, so you're not eligible, or you are. And if you are, then you get 6 months in which no generic manufacturer can come to market. So that's, I guess, the way it works. FDA, in other words, another way of saying it is that FDA does things that have relevance to the questions that you're raising, but prides itself in administering them by not paying attention to those factors, if you will, if that's at all helpful.
Just to provide a little context for people who might not understand the specifics. So REMS is the risk evaluation mitigation strategy. So it's for drugs that have potentially more serious side effects. So if you ever look at a drug label and it has a black box warning, that would come from a REMS strategy. So I can send a link out afterwards to explain what REMS is for those of you on the call.
All right, thank you so much. So this is our last question. We'll do an easier one for everyone else.
Time, I think.
I know it's been hard questions after hard questions all night. So, are clinical doctors going to use AAP recommendations for vaccines or the CDC?
I can't speak to what clinical doctors would do, but based on my limited knowledge of what's happening, I would assume I shouldn't assume. It seems like it would make the most sense to go with the AAP recommendations. But as Dr. Laurie said, because vaccines under such scrutiny, it's possible that taking any information from CDC's content isn't the worst idea. But if you're asking whether they should use the AAP's recs, then I would probably say yes.
Well, it's a sad reflection. A former federal employee, right, recommending that you use a non-physical.
Sorry.
But yes, I think that makes total sense. So I'll answer in a slightly different question. I agree with what Vera said, but I'll add this, that it's not just a matter of recommendations, right? The vast majority of Americans actually believe in vaccination, and vaccination rates, although declining, are still high. Not for COVID, but for everything else. All the childhood vaccinations are still well up in the 90%, but they're on decline. And sometimes, of course, as we all know, they get down below the necessary herd immunity levels, and then you end up with a measles outbreak like they did in Texas. But RFK can manipulate more than just the information that is provided. When a vaccine's indication is constrained, the way they just were, then it means that an insurer does not have the same obligation to pay for them. And when that starts to happen, that can have a real impact upon vaccination rates that's independent of advice or even the information ecosphere, right? It's the policy ecosphere that's going to set the stage, and so people are going to be afraid to vaccinate in ways that go against the FDA recommendations. Even if there's the AAP to back them up, they're going to be worried, and that might get them to push less hard to vaccinate. It might get them to not stock some vaccine that they otherwise would. So all of those things, they build on each other, and that's in a way the most frightening part. We shouldn't think of this as strictly an informational question. We should look at the ways in which literally every policy lever available to RFK is being pulled. The ACIP, the VRBPAC, the two advisory committees. He's looking at vaccine injury and how that's managed. Right. Soon enough, he's bound to turn to the VA and the DoD, since those are, healthcare systems controlled by the government. It's only a matter of time. So it's all of these different ways, and they're mutually reinforcing. And at the end of the day, the message is, don't trust those vaccines. And I think we'll see vaccination rates continue to go down.
Well, thank you, everyone. I'd like to close the session by thanking Dr. Peter Lurie and Vera for such a thought-provoking discussion tonight. And we're just so grateful to have both of you guys, be able to join us and share your experiences and also your time at the, CDC and the FDA. So before everyone leaves, just a few quick reminders. One, education is important, and so is action. So after tonight, session, please take the following actions. One or all. One, we'll start with join our monthly FDA task force meeting to keep the fighting going. Okay, and write an OPAD, like get involved, write a letter to the editor, to your local paper, so that people are aware of these things. And three, really invite others to join the DFA work. That's really, really important. That way we can get more exposure out there, and we can have more people join in on our fight. And above all, thank you so much for being here. And to all of you, on behalf of your patients and your communities, we hope you'll become an official DFA member today. Please see the link in the bio here today. And the number one reason why doctors, medical students, and advocates actually joined the FDA. I should say the DFA, is actually because we are surrounded by like-minded people and people that share the same values, same priorities, and we put our patients first. So please take the time to join our community, Doctors for America. And yeah, well, tonight it's been a whirlwind of what the FDA, what the CDC does, and I hope you guys have learned a lot. I sure have. And if you want to get involved, if you need more information, please go to our website. Well, thank you for attending, and we hope that you have a great rest of your evening.